second annual lecture in honor of this gentleman, Dr. Jong-wook, who was the Director General of the WHO, and as we'll see a little bit later, a personal friend of two of our faculty members. We did this introduction last year. I'm not going to give a lengthy introduction here. We'd like to get to the speaker. But suffice it to say that from everything that I've read, and I encourage you to go read, on Wikipedia and go down the internet rabbit hole. Lee Jong-wook was an amazing individual, and there's just so many things to learn about. And the personal story where our faculty members, Drs. John Hess and Lynn Stansberry, actually were very close with him. These are just a couple of his interesting quotes here that you can see. The one on the left, I think, is particularly germane to things that we've all experienced today. The most important health problem in the world is the lack of the rule of law. I think we all can understand that, and that's something that this individual dealt with for his professional career. Here is sort of at the beginning of the relationship, and for those of you who have met Lynn Stansberry, that's a very young Dr. Lynn Stansberry on the right there, in Hawaii with Jong-wook's family, who lived with them for quite some time, and that's one of the ways that their close bond grew. They met in 1978 when they were both working in Korea. John was with the U.S. Army, and Jong-wook was in an emergency room in a small hospital. And then they eventually did live together when earning a master's in public health degree at the University of Hawaii. That's him, his child. And so these are, as I said, Drs. Hess and Stansberry, who have endowed this lectureship in honor of their friend and this real august figure in public health. And John, when he decided to, and John and Lynn, when they decided to endow this, said what they'd like to do is they'd like to endow a lectureship that spotlights the role of the laboratory in the health of the public, in public health. And so that's why we're in a public health building right now. And last year, we heard Dr. Alex Graninger tell us about the impact that COVID testing had on the pandemic that we all really know very well and very personally here. And this year, we are moving to a topic now for something completely different, but not actually as different as you'd think. We're going to hear about LDTs, IVDs, and the FDA. Our speaker today will be Dr. Eric Konnick, well known to many of you as one of the faculties in our genetics and solid tumors area, and really is one of the linchpins to our approach to doing cancer genomic testing. In that area, though, I think all of us in this room understand, or at least those of us who are employed in the department understand, that what he does is laboratory-developed tests. And we're going to hear that these are procedures that we carry on in our laboratory, that we're inventing these things, but we're potentially going to experience a degree of regulation we have not in the past, and that might have some bad outcomes. And so we're be interested to hear from Eric about that. Eric's history is, I just give a very brief bit. I have his very, very, very thick CV here too, and just to highlight a couple things. One of the terms I learned in medical school, by coincidence at UC San Diego, I did medical school largely at the Navy Hospital, and so I learned a term in the military, which John would probably appreciate, which is in the military what a Mustang is. It means someone who started off as an enlisted person and then got a commission and became an officer. And so every once in a while in our profession, and I know there's some other faculty, not just Eric, people who work in the front line as lab techs or laboratory scientists and then eventually become faculty. And I think Eric, by having done that many years ago at ARUP, I think he has a really great appreciation for all parts of our business, from the bench work side all the way to the bedside and everything in between. And so I should also just mention, he was in 2018 awarded with the Outstanding Clinical Pathology Resident Teaching Award, and he is currently the president of the Washington State Society of Pathologists. So without further ado, I would like to introduce to you the March 2005 Employee of the Month at ARUP Laboratories, Dr. Eric Konnick.
Thank you, Jeff, for that warm introduction. So I'm getting over a cold, so if my voice breaks, I apologize. So some things I'd like people to come away with today, are thinking about, everything we do every day is for patient care and, at writ large public health. And there's lots of regulations that potentially impact what we're able to do for our patients and our communities. And there's different ways that regulations happen. So come away with an appreciation for what those different ways of getting to regulations are. There's also been a number of turning points over the last decade related to laboratory developed test regulation where things changed either slowly or suddenly, and I just want you all to have an appreciation for what those were. And then the other part of it is many of us here are on the front lines. We're physicians, we're scientists, et cetera. And oftentimes we get into this mindset of just dealing with what's in front of us. But there is this much larger context we have to think about, and influencing what the laws are, what those regulations are, has a very, very important effect on what we're able to do day to day. And so I want to share with you some of the lessons I've learned, sometimes easy, oftentimes painful, so that as we go forward, you can all have a impact as well. So, when I was awarded this lectureship, John and I had the chance to talk for about 45 minutes, about the life of Lee Jong-wook. And, one of the things that really came across to me was that, where he started and where he ended up, you couldn't have predicted that end state based on where he started. It's not surprising in retrospect, but I kind of feel the same way. So Jeff kind of mentioned a little bit where, I started as a bench tech a long time ago. And if you had told me, at that point where I would be and that I would be talking about regulation today, I wouldn't have believed you. So I'm going to give you a little bit of a flavor of how I got where I am right now. So this all starts with residency. So my very first day of core lecture, so I matched here and I started on clinical pathology, which was a little atypical. And the very first day of core, Dr. Rainey, who is the residency director, said, you should join a CAP committee to all the residents, not just to me. And I said, that sounds like an interesting idea. So I applied. And I applied to things related to cancer and all the things I do day to day now. But at the end of this application, which was paper back then, there's a little box that said, any CAP committee that will have me, sign me up. And so there was a long, drawn-out process. And the next year, they sent me a letter and said, you're on the political action committee. And I was like, okay, that's kind of weird, but we'll do it. So I joined this committee for a couple of years. And in 2014, there's always a meeting in Washington, D.C. in the spring, and I screwed up my travel arrangements. So I went out a day early, or made my plane reservations for a day early. And just by happenstance said, hey, can we go up on Capitol Hill and go tromp around the offices? And didn't really have an agenda, but I just wanted to do it. They said, sure. So on March 27th, I went up to Capitol Hill, and it was complete chaos. And the reason was because the night before, a little law called PAMA had been passed by a voice vote. So people on the floor of the Congress basically said, yes, we're going to pass this. And nobody was really expecting it. Nobody knew what the implications for this were, both on the CAP side as well as the offices we visited. So what this particular law does, now we understand, was basically reduce the amount that we get paid for a bunch of different laboratory tests, and pretty severely year to year. So up to 50% reductions over a couple of years. And it has broad implications for our ability to do our work. But, flashing back to 2014, this was proposed as something, a legislative fix to something called the doc fix. And this was basically every year physicians would take a pay cut that was mandated by a previous law of a couple of percent. And every year Congress would say, just kidding, we'll delay that. And so every year it would just be cumulative. And there was something like if it passed, it would be a 60% reduction in primary care reimbursement. So it just was not feasible to do. And to fix it, they basically took it from the laboratory side of things. But on this particular day, again, there was no understanding of what the implications for this law were. And every congressional staff I talked to They didn't understand it. The CAP people didn't understand it. And I had a really, really long conversation with then Representative McDermott's staff about this, and it was just a lesson. The other thing was I don't remember what I learned in junior high, like how laws are passed, how this whole system works. And so, just this one experience, I had to go back and relearn all this. So my lessons from this are pretty simple. Legislation can move fast, and it's all related to deals. Somebody is making a deal to get what they want, and it may impact somebody else in expected or unexpected ways. It was also this idea that you really need to understand what's going on. What are the bills that are potentially going to impact our ability to care for patients? This idea of vehicles. So basically, the way our legislative system works is you can attach one bill to another bill that's going to get passed, and they get passed together. So what are those vehicles? This other idea of vigilance. One of our leading organizations didn't know this was coming, and they just weren't paying attention. And so we have to pay attention to all the things that are going on in Washington, D.C. and locally. And we also have to use our professional societies. So fast forward a couple of months, was here starting my fellowship in molecular diagnostics, and was having a great time doing laboratory work. And then all of a sudden, this little document was released at the end of July. And this was a proposal from the FDA, which is called a guidance document. And this guidance document, I think it was 90 or 100 pages long, something like that. And the whole idea was to regulate laboratory developed tests. And because of the lessons a few months before, I started reading into this. And I didn't understand a lot of it, but threw myself into this to try to understand. So basically the root of things was this idea of we buy a lot of kits from manufacturers. Those kits often go through the FDA. They're either cleared or approved, and then they're sold to us, and then we implement them for our patient care. These are called IVDs, or in vitro diagnostic tests. We can also do something called laboratory developed tests, where we use our understanding of medicine, our understanding of technology and science to develop a test that is important for patient care. We build that test, we validate that test, and then we offer it to our patients. For many, many years, the FDA has said that they have the authority to regulate us, but they're going to use quote-unquote enforcement discretion. So there's these two different pathways for bringing a test to our patients. And the whole proposal that they had back in 2014 was to basically consider all of us in this room manufacturers. And so all the rules that the manufacturers, Roche, Bayer, Siemens, et cetera, have to go through would apply to us and all that infrastructure they use. And we would have to seek FDA approval. We would have to submit documentation. They would have to approve us, et cetera. The other thing to remember is we oftentimes modify the tests that are FDA cleared or approved to actually care for our patients. So what those tests are may not be 100% appropriate. We may need to automate them, et cetera. And so we would have to submit those to FDA as well. And we'd have to abide by all the other regulations that we do day to day. So clinical laboratory improvement amendments, our CLIA, as well as our state regulations as well. So throughout this whole process, I learned that there's a couple of ways that you can create regulations. And this is my very crude summary of them. The one on the far left is basically Congress can pass a law. And if they pass a law, once that law has been passed, they give that law to the regulating agencies, whether it's FDA or EPA, et cetera, and they come up with the regulations based on whatever that law was. And those regulations have the force of law. So if you don't follow the regulations, you're breaking the law. It's pretty straightforward. The other thing they can do is something called notice and comment rulemaking. And there's a really long and drawn out process. One of the key things is that whatever the agency is, they have to have the authority, which was given by Congress, to regulate whatever it is they want to regulate. And they can go through this process of coming out with the proposal and getting comments, responding to the comments, on and on and on. And at the end of the day, when they issue that final rule, that has the force of law. The final thing that you could do is something called guidance. And this is something that FDA has been using for decades. And this is just basically what our current thinking is on the matter, but it doesn't have the force of law. And so if you follow these things regularly, you'll see FDA is releasing guidance on all kinds of different things all the time. And even though it doesn't have the force of law, they treat it that way. And so if you try to go to the FDA and saying, well, this is just the way you thought about it, we think something different, they'll point back to their guidance and this is what you need to do. So again, thing on the right is what they were doing in 2014. So and the rationale was that, laboratory developed tests have changed. It used to be a cottage industry where we would do simple tests, for our local patients, and it's gotten much more complex, and there's the chance that things could go bad. There's also, this common theme that, the regulations that apply to us weren't enough. They didn't have any idea what tests were being done. And one of the other core things was, what designates a good lab from a bad lab? They're all legitimate questions, but they really didn't have any good data at the time on this. So just kind of looking at the arguments, there's different things that the FDA will require versus CLIA. Some of the things I'll point out here. So analytical validation, FDA claims that we only look at after the fact. But we do that on a regular basis through proficiency testing. There's FDA claim there was no clinical validation, but I would argue for all the medical directors in here that that's part of your job, is to make sure that the test that you're offering actually is able to identify what it is that you want. And then adverse event reporting. I think all of us here, hopefully not all of us here, but there are things like errors that happen, and we can have a way to report those through the hospital, et cetera. So these are some of the reasons why. And back in 2014, it wasn't really clear, we knew this was going to be a problem, but how big of a problem was it going to be? And so this is actually data from the University of Utah from, I believe it was this year. And what John Genzen and colleagues did is so AREP is a large reference laboratory associated with the University of Utah. And what they did is looked at all the tests that came from the University of Utah for University of Utah patients. And what was the breakdown between FDA-approved tests and laboratory-developed tests? And in this case, they had about 3 million tests that they looked at and about 2,000 individual assays that were part of this data set. And what they found was the vast majority of tests, so almost a little over 2.8 million of those, were using FDA-cleared or approved platforms. It's not really surprising because the tests we use a lot of the time, those are things that we use in high volume and manufacturers would like to make money off of. Laboratory developed tests were a much lower percentage of the total number of tests. But if you look at the number of assays that were involved, it was actually fairly close. And so, that 2.8 million tests was using almost 1,000 FDA cleared tests, and the LDTs were almost 900. And the reason this was important is because during this period of time, there were multiple hearings that were held at the FDA campus, and people like Ed Ashwood, who was at that point CEO of AREP, got up and said, if we had to go through this regulatory process, given what we know, 2/3 of these LDTs we would have to stop because they would not be, it would not be economically viable to do the FDA approval process. It's just too expensive and too onerous. And so thinking about that, out of that potential 900 tests, 600 would not be available, right? So the numbers are small, but potentially the impact could be huge if we took those away from patient care.
Question, Eric? Could you go back?
Yes, Mary Clay.
Why was the article titled as it was? The article title, a small minority of tests ordered in an academic hospital system, is clearly correct, but it doesn't convey the devastating impact that you've just described.
That is a very good question. So I don't know if people were able to hear. So the title of this particular paper was that the number, so the title was Laboratory Developed Tests Account for a Small Minority of Tests Ordered in an Academic Hospital System. I think there's a little bit of foreshadowing, and I'll get to that a little bit later and come back to it. But thinking about that title, there's potentially a reason why they titled it that way. So we all know that there's a bit of salesmanship with a lot of things we do, and that I think that's potentially the case here. So, excuse me. So some of the things that happened over the next couple of years was a public docket was established. You can go online and read most of the responses that were submitted. There were about 170 comments at the time. A few have been withdrawn, so you don't have access to them anymore, but the vast majority are still there. I'll point out that there were numerous comments from our center, and so I look around the room, I can see a couple of the authors specifically for that. And I will say that other academic centers may have had one comment, if any, so we have a disproportionate number. I'll also say one of the things we did was, as a department, was got together and put together dozens and dozens of letters, which I personally took up to Capitol Hill and delivered to congressional offices. Big, thick, 4-inch binders full of this is why this is a bad idea. There were also multiple in-person meetings. There's verbal statements, written statements, etc. And I can break it down, into a couple of categories. So manufacturers, they were very supportive of this. They want a level playing field. And by level playing field, they think that there's some sort of competition between what we do day to day and what they're selling to people. They also made an argument for patient safety, but didn't have great examples. Patient groups and some oncology groups were generally supportive, but their ideas were basically we need safe, reliable, reproducible tests. I think we can actually demonstrate that that's what we have. And then if you look at the practitioners, the people who understood what the implications were, this would definitely decrease our ability to innovate. It would restrict patient access because we wouldn't have potentially 2/3 of the tests that we have now, increased costs, and there's also a big concern for monopolies. So this was going on for a couple of years. The general process for guidance is basically they draft it, they take their comments, they respond to it, and kind of the last stage is basically taking it to the Office of Management and Budget as part of the White House and getting comments on it. And our best understanding is that this is where this guidance was in 2016, late 2016. And so there was a very, very real chance that January, February of 2017, this would be what we were operating under. But something happened. And this, I personally didn't expect this. I think a lot of people didn't expect this. But it really changed the landscape literally overnight. Within 2 weeks, FDA came out with a statement saying, that thing we've been doing for the last 2 years, we're going to hold off on that. And it literally, so that was on the 8th. This is the 16th. This is the Wall Street Journal piece on this. But they did release a paper a couple months later that said, kind of here are our ideas, here are the things that we want to, we would do if we could, et cetera, kind of summarizing what they've been doing. So, the lessons I got from this was, reflecting back to what I learned from PAMA was you really do need that awareness and understanding and do need to pay attention to what's going on. And it was the ability for the community to kind of recognize this and have a cohesive response. There's lots of ways to express your concern. There's official ways, unofficial ways, but we have to use all of them. And I think that's why, a lot of the comments and impressions we had with legislators were heard. And there's always the chance for these unexpected derailments or changes, and really nobody expected things to change that quickly in November of 2016. The other thing that was interesting was the role of professional societies. And so personally, I was just kind of winging it at the time and putting in comments and, submitting things where I could. I didn't really have any framework to do any of this. But what I found was the picture here is of Roger Klein. So he's a physician and a lawyer, and he was one of the key people in the AMP versus Myriad Supreme Court case. And so Roger, being a lawyer, has interesting thoughts on this stuff, and so he and I would talk, and he invited me to become a member of the Professional Relations Committee of AMP, and so to take a more formal role in their response to things like this going forward. Okay, so now I was fortunate enough to stay on as faculty, and so here's kind of the things that have been going on since then. So beginning in 2015, there was a group that got together. So this is called the Diagnostic Test Working Group, and this was a group of manufacturers and large laboratories. So you can see the names there. One of those is ARUP, where John Gensen is practicing. And what they did is they hired former Utah Governor and HHS Secretary Mike Leavitt, who now is in private practice with Leavitt Partners. And they have a lot of deep understanding of the government and the health system, et cetera. And so they hired this law firm to put together some ideas about how we should regulate things. And I'll point out they've spent, so this is a little old data now, so a couple of years out of date, but they've spent at least $1.75 million on lobbying. So when you spend that much money from these companies, that's kind of the perspective you get. And one of the things that they did that was interesting was they put their ideas into legislative language. And then they found people congressmen, so senators and representatives, that were interested in this and basically got them to introduce this as legislation. And what that legislation did was a couple of things. So again, it kind of breaks up responsibilities for FDA, responsibilities for CMS or CLIA, and then responsibilities for states. And one of the things that was really interesting about this is that they wanted to not just reform the system, but create whole new infrastructure within the FDA, which is a new center specifically related to lab tests. And so basically the way it would break down is if you created a new test, that was all in the FDA's jurisdiction. Once you brought that into the laboratory to use on patients, then it would fall under CLIA and CMS. And then once you as a professional interpreted that, that would be state regulations, medical boards, that type of thing. So, and the legislation was really interesting because it was broken out in such a way that you can imagine this idea of dealing, like, oh, well, let's take this out and put that in. And it was modular in some ways. And there were literally parts of the legislation that were designed to be thrown out as part of the negotiation process. And so a couple of years later, this is all going on. A couple of years later, they recognized that one of the important areas that they had to focus on was academic medical centers. And so they formed what they call the Scientific Advisory Board. And they picked individuals from each one of these institutions. I'm starring Duke there because at the time, the former and now current commissioner of the FDA was a faculty member at Duke, Dr. Califf. And so Duke has taken a really strong role in leading on this particular issue. But it was all, I want to say word of mouth. So it was like who knew who. So somebody from one of these institutions reached out to one of our former faculty, Dr. Brent Wood, and said, would you like to be a part of this group? And Brent's learned a lot of lessons that I've yet to learn, like saying no. And he said, I don't want to do this, but let me put you in touch with Eric. And so what was interesting about this is that all these groups here were very interested in regulation happening, and I was not. So I was definitely the contrarian on this group. So again, throughout all this time, what was happening is multiple legislative drafts were happening, but the whole idea behind this was basically get something into Congress and have that be the starting point. Because I think any of us who've written a paper know it's easier to edit than it is to write, from whole cloth. And that was their whole point, was basically get something in there. This is the starting point. It has our interests at heart. There's some stakeholder input, but that's where they wanted to start. And as part of this whole process, they found sponsors in the House and the Senate, one of whose is our current Senator, Patty Murray. And they requested something called technical assistance. And this is from both CMS and FDA. And the whole idea behind this is, here's what we're thinking of proposing. Give us some feedback. Typically what that means is like, I don't like this particular word, and they literally put a red line through it. Or say, this isn't going to work for XYZ reason. That's typically how this stuff works. So this is a little timeline where I'm going to keep coming back to. I'm going to highlight where we're at. So again, draft guidance comes out in 2014. 2015, they have a hearing on this, LDT regulation. The DAIA, or the Diagnostic Accuracy and Innovation Act, is introduced by Representatives DeGette and Bouchon. And then in 2016, again, we have the election. They delay their guidance process. DAIA goes through a couple of different iterations and is submitted to the FDA for comment. So they submitted in March of 2017, and we wait, and we wait, and we wait, and we wait until August of 2018. And then the technical assistance is released. And what was interesting about it was not like any technical assistance that had ever happened before. Number one, they released a multi-page document that kind of said, here are our thoughts about it. Here's, we don't endorse it, but this is our thought. It wasn't this red line thing that we were expecting. And then a few days later, they released what was essentially a legislative proposal in legislative language. So they basically had taken this idea from this DTWG group, thrown it out the window, and written a whole new law, or a whole new bill that would potentially become law, and said, this is how we want to do our job, which is apparently something that they're not allowed to do in any other case. So this got a lot of attention. So if you, I call this now my perverse hobby of following regulations and what's going on at FDA and things like that. And so the FDA law blog has some interesting things from time to time. And Jeff Gibbs is a really well-known attorney in this sphere. And they called it out and said, this isn't technical assistance. This is something different. And what happened over the next couple of years was they took basically everything that FDA had written and turned it into a bill that was called the VALID Act. So the VALID Act came from something totally different with a whole different set of ideas. And again, one of the things that the DAIA group did was they were very strategic. So again, using Mike Levitt's understanding of the government system, his understanding of HHS, et cetera, they found people in the House, they found people in the Senate, and introduced this who were not just Democrats and not just Republicans. So bipartisan, bicameral. And so, from the get-go, there was a lot of agreement among what was going to be put through. Going back to junior high, just to remind everybody, if we pass a law, it has to pass in the Senate, it has to pass in the House. Once you have those laws passed, they get together in what's called a conference, and they work out any differences. They come together with a single bill, distribute it back out to the House and the Senate. They have to pass it again. If they pass it again, it has to be identical language. It goes to the president. President has a chance to sign it or veto it, of course, overrule it, et cetera, and then it becomes a law. So the folks who were setting this up were very, very savvy, thinking about this as a multi-year game, how to get it through all these different processes. So this, was at least on the 50-yard line from the get-go. So again, what are some of the things we learned here? So I thought it was really interesting to engage with this group of people who are very pro-regulatory, and again, argue my points, let them argue theirs. Probably spent way too much time on it, but it was an interesting exercise. This idea of legislation transformation, I don't know if this is a correct term, but this is kind of how I thought about it. So many, many years ago, I talked with some lobbyists on Capitol Hill, and I said, well, why don't we just create a bill for what we want to do and get it into Congress and then see what happens? And the lobbyists kept saying no, because what'll happen is you lose control. And so what I kept thinking about, so I'm a Star Trek fan, this is from, must be the early 90s. So Captain Picard is becoming a Borg in this scene, right? So they basically taking him over, they're gonna make him into their instrument of Borgness. That's essentially what happened here. So they took this other law, took it into the FDA, and turned it into the Borg. So the other thing is this strategy, right? So bipartisan, the Republicans and the Democrats coming together, having a nice dinner, bicameral House and Senate, making sure that this is set up so that it could be passed if possible. So interesting things that I learned there. Now, the last couple of years have been very busy related to the VALID Act. So again, we had an introduction in 2020. Every 2 years when Congress lets out of session, anything that didn't get passed, it basically evaporates. You have to reintroduce it. So that happened at the end of 2020. In 2021, they reintroduced it again. So now we have something to think about. Okay, how is this going to potentially impact our practice? So as a person who does molecular oncology for oncology patients here, this was a really interesting piece that was created. So Richard, who's the first author here, he's a physician who's at Foundation Medicine, and Joan Lennertz is a physician at Mass General. And so they basically took the VALID Act and said, what's it going to cost, for our oncology patients? Just thinking about just these high-risk tests, these things we do day to day. And so they came up with a range, and they weren't, they said, well, could delay tests somewhere between 6 months and 8 years, depending on how FDA decides to do this. The additional cost per test on the low end was estimated to be about $62 per test, up to $266. And the total cost would be, $500 million to $3 billion plus. And what I can say is that the cost per test is actually probably pretty accurate. And so we can look at tests that were previously laboratory developed tests that got clearance through the FDA and what the increase in cost was. And it's about a 15% jump So basically, tests that the day they became FDA approved, their cost or their price jumped 15% across multiple tests. So, the potential cost of this is enormous, and you can imagine, there's already financial toxicity for our cancer patients. This is going to decrease access if this happened. So, we have an idea of like the total number of tests that are potentially going to be impacted, and then this isn't even counting the fact that there will be monopolies, tests will go off the market, there'll be limited supply, et cetera. This is just what the cost of the regulation is estimated to be. The other thing we've had over the last couple of years, as Alex spoke to last year, was we had a little pandemic. And in the very early days of that pandemic, the FDA put in process that required all of our tests to go through what was called an emergency use authorization process, EUA. And there was a shortage of tests for a long time in those early days. And one of the lawyers who worked for the government was really concerned that there was a shortage of tests. And so he started looking into it. He had the authority to do that, and so he started doing a deep dive. And what he did over the course of several months was come to the conclusion that the FDA actually didn't have the authority to regulate laboratory-developed tests. And he issued a memo, which doesn't sound very impressive, but what's really interesting is that in this context, that memo stopped the FDA from regulating tests with the EUA process, especially in academic centers like ours. The other part of it that was really interesting, so this is actually the link to the memo, and here's the cover sheet of it. So Mr. Charo there is the general counsel. The other part of this is that Mr. Charo said, FDA has been trying to regulate lab tests using guidance for years. They don't really have the authority. And with that one memo, basically said, this is not legal. You can't use this pathway for this particular purpose anymore. And what's interesting is since this came out in 2020, FDA has not tried this particular route of regulation again. They've switched to some other things like notice and comment rulemaking and also legislation, but they aren't using that specifically for laboratory test regulation. So 2020, and then what's happened the last couple of years too is we've seen this interesting push from public interest groups, for example. So the Pew Charitable Trusts had a very, very strong campaign saying, laboratory developed tests are dangerous, and had very interesting things that they put out. They were somewhat informed, but not great. But this had a high profile because of that organization. The other thing that happened is we see really high profile media outlets like the New York Times came out and said, we have these problems with these lab developed tests. And very splashy headlines got a lot of attention, got congressional attention, and so on and so forth. And they led to FDA coming out and saying, we have concerns about this, and actually putting out safety warning for non-invasive prenatal tests, which are common, ubiquitous, if you will, for testing pregnant people who may be at risk of having a fetus with chromosomal abnormalities. So there's this kind of steady drumbeat that's going on in the background of like, we need regulation, we need regulation. At the same time, there's this other kind of overlying process. So one of the things that I certainly didn't appreciate a long time ago was how much of what FDA does is funded by money that we pay to the FDA for doing that task. So they do have some funding, but a lot of it is paid through what's called user fees. And so what we can see on the left-hand graph there is if you're a pharmaceutical company, the cost, the amount of money that you're paying to the FDA to get your drugs approved has been going up dramatically over multiple years. And about 70% of that cost is borne by money that you pay to the FDA to regulate your product. If we look at the device industry, so devices include hip implants, knee implants, defibrillators, et cetera. Also happens to include lab tests, just because of the way the laws are structured. About 40% of that cost is borne by us as an industry paying fees to the FDA to get things approved. And so you can kind of see that trend increasing. The law is that every 5 years, FDA has to go back to Congress and say, we want you to reauthorize our ability to collect these fees to keep doing our job. And so these are called user-fee amendments, or UFAs is how they're often called. And so there's PDUFA, which is for pharmacy, MDUFA, which is for medical devices, and on and on. But it's a multi-year process. They have to go out, they have to get, stakeholders, et cetera, et cetera. So this started all back in 2020. And so what they were trying to do was, remember how I talked about vehicles attaching things to legislation? Well, this is something that has to pass. If this doesn't pass, the FDA shuts down. They can't do their job. So last fall, this had to pass by October 1st, or they would start laying off people at the FDA. And so this was viewed as a potential vehicle for passing the VALID Act. And so beginning kind of in the spring of 2022, there was a push for this. Unfortunately, there's delays. And so the PDUFA, the pharmacy user fee amendment was probably the most important. There were a bunch of delays because FDA wants to charge more, the pharmaceutical companies don't want to pay as much. So they got delayed, so they were behind the eight ball. The medical devices are also behind the eight ball as a result, right? These are just stacking up. And in the Senate, they actually attached the VALID Act to their Senate bill. Didn't happen in the House. They had to get together and hammer these things out. And pretty much at the 11th hour, I think it was back in June of last year, VALID didn't get included in these user fee agreements. So what happens now? They get a second chance. So because of shenanigans in Washington, D.C., they're not going to fund the government through the end of the year. There's going to be another set of bills that come up kind of at the end of the year to keep our government running. And so, again, September 22, VALID isn't passed. But again, they're going to get a second shot. And so kind of about the same time, Dara Eisner from University of Colorado, Jeremy Siegel from University of Chicago, two colleagues and good friends, they were concerned. They were concerned that there wasn't enough going on here. And so they wanted to do a grassroots effort. And so they came to me with some ideas and things like that. Not necessarily asking for help, but we streamlined the message and got together several letters, basically reached out to colleagues around the country, mostly in molecular diagnostics, and got 300 physicians and PhDs who do this testing day to day to participate in signing letters, sending them to their congressmen. And we were lucky enough to have some resources from the University of Chicago and set up multiple meetings with people on Capitol Hill. So, again, we have the professional organizations, we have our university efforts, we have this grassroots efforts, we have all these things going on kind of at the same time, trying to say the same message that, the regulation is gonna cripple our ability to take care of our patients. So, going to into November, the VALID Act very much looked like it was going to be included in this final end-of-year funding bill, and it was moving like a freight train. They recognized there was a lot of resistance from academic medical centers specifically, and put in some potential exemptions that were really non-exemptions, trying to get things smoothed out so we would be on board and support with them. So again, this is early December of 2022. And this is just a headline from one of the industry journals. So literally at the last minute, December 20th, VALID wasn't included. And it wasn't really clear what had happened. There was a lot of pressure, a lot of things going on, but everything that everyone was hearing was basically this particular bit of regulatory legislation would have gone through. And towards the tail end, when all this was happening, we had a really strong investment of time and resources. Andy Hufnagel, Tina Lockwood, Dr. Baird. We have government relations staff we were working with, getting meetings with folks on Capitol Hill for our representatives primarily. And one of those meetings was with Kathy McMorris-Rogers, who isn't in our district. But we had a really good discussion with her in early December, actually her staff person who dealt with this. And they understood what the rationale was here. And what we found out later, this is from Politico Pro article, the thought is that basically one person, so Kathy McMorris Rogers, was in a very powerful position with the Energy and Commerce Commission, apparently single-handedly stopped this from happening. And it was probably, somewhat related to the fact that we had a call with her. So again, this was just one meeting among many that we were having, just a full court press, just trying to do what we thought was right. And, one thing made a difference. I thought this was kind of an interesting comment. So this particular Karen Tannenbaum was formerly at FDA and back until 2019. But, one of the thoughts was that throughout this multi-month process, there were a lot of people having input, a lot of people with concerns. It wasn't just, a very streamlined process that people on the Kill wanted. And I thought it was interesting that somebody with insider knowledge was basically like, this was too prolonged, and like people who didn't necessarily know what was going on, had an input. And it brought me back to what happened with PAMA, where people who would have be very, very affected by this legislation didn't understand it. They didn't have the input. And, now we're living with the consequences. And this is the converse, where people who are really going to be impacted, we got the word out, they were able to influence the process in a way that I would say is a positive. So, got through the end of last year. Where are we now? So there's a couple of things that could happen. So there are groups that still want to reintroduce this legislation, either as a standalone bill or attach it to other legislation, or there's some other things that could happen. Some complications. So again, there was another election. One of the House flipped sides. So now we have the president's democratically controlled, the Senate's democratically controlled, the House is Republican controlled. Less happens when there's divided government. So that's a complication. The second thing is two of the chief sponsors have moved on. So Senator Murray has moved on to a different position within the government, so has less control over what happens in the healthcare sphere. And then Senator Burr actually retired and is now got hired by a huge lobbying firm. And so he will soon be on Capitol Hill, advocating for his new clients. So we're currently in the 118th Congress. Valid has actually been reintroduced just on the House side. So that means that it's probably not going anywhere. There are a couple of bills coming up this year it could be attached to, but if it's not on the Senate side, it's unlikely. And then we have user fees again in 2027. The other thing that's going on is the FDA recognizes that there's an issue. So, especially in the cancer space. So a lot of the new cancer drugs require a lab test to identify the patients who are going to benefit. That slows down the drug approvals. This is one of the heads of one of the parts of FDA, Dr. Pazer. And this is such a big concern that they're actually talking about new ways to take testing out of the FDA regulatory scheme to make it easier, right? So within the agency, you have one side that's like, we need to make these things tougher for laboratory developed tests. And this side saying we need to make it easier. Again, we also have this steady drumbeat of things that are inflammatory, if you will, saying that we need more regulation. So Dr. Shuren is the head of CDRH, basically saying, we need more regulation. We don't know what's happening here, and out there still pushing it.
What's CDRH?
Centers of Device and Radiological Health. So that's the part of the FDA that's responsible for laboratory testing. Then we also have, so remember I mentioned Commissioner Califf. So he was commissioner under President Obama, took a couple years off, did some work at Duke. Now he's back as commissioner of the FDA under President Biden. So he's also saying, if we don't get a law passed, we're going to regulate laboratory developed tests by any means necessary, including notice and comment rulemaking. So again, we have one pathway shut off by a legal memo through HHS. We're probably not going to pass a law anytime soon. So they have this last way to pass regulations. And back in June, there was a very small release that said FDA is going to pursue this particular avenue. And apparently it's going to be released this month, is what they claim. So we will see. It's very early in the month, but we may have something to contend with. As part of the rulemaking process, this is a very long and drawn-out process and can take years, because there's a lot of back and forth between the agency, between the public, stakeholders, et cetera. One of the things to pay attention to is, so right now we're at where the arrow is. So we're kind of in the we're in the OMB process. So basically it's at the White House, they're reviewing this, and if they approve it, it'll be released. At the same time, there's a bunch of places that we can intervene. So there's meetings that we can request. We can comment publicly on things. We can have more meetings. There's all kinds of fun meetings we can have here. But it can take a long time. One of the things that we have to, so again, thinking about all this strategy stuff that I talked about previously related to VALID and DIA and all those other legislative proposals was, there's an interesting part of the law around regulations where if there's an election and you pass regulations up to 90 days before that election, whoever wins can basically just wipe those out. So if you happen to get your regulations in place 91 days before the election, then there's nothing that the new administration can do. And so you may have heard there's an election next year. And so a lot of the consultants who work on this say that FDA is really going to push this hard. We'll probably see something come out this year, and they will push really hard to have it in place 91 days before next year's election. So even though this can be a long and drawn out process, there's potential for things moving very quickly. So again, thinking about all the things I've been talking about, there's probably a lot of stuff we'll have yet to do. So what have I learned? So timing, is there a vehicle, is there a way that this can move quickly? It can move really, really fast. Politics, how are these things set up? Are they set up to move quickly or slowly? Again, all these things of, using all the different relationships we have, with each other, with our institutions, with our organizations, how can we get this, how can we influence the message? We have to think about, what is the media saying and how are they getting this message? Is there a way to countermand it? And then also this idea that even within these regulatory agencies, there's now a split because they recognize that there's a problem, but they have different ways of solving it. So, and that's, kind of the end of things right now. So lots to do. There's many ways that regulation can come to bear, and hopefully I've highlighted some of those. And I think thinking back to, this is obviously a public health lecture, and again, we take care of individual patients, we take care of individual samples, but we also take care, of our entire community, and writ large. It makes a difference how we're able to leverage what we do day to day to society at large. And we should participate. And there's lots of ways to participate. But we have to be aware. We have to be flexible, right? And you have to be able to say, I'm going to change how I'm doing my advocacy around this. You have to do things in multiple ways, right? We're going to write letters. Sometimes you'll have to give testimony. Sometimes you'll have a meeting with people locally, with our institution, nationally, et cetera. Professional societies are really important, and getting the word out and kind of leveraging other people's experience. And the other thing is that even when things look dark, we still have to kind of push forward and do what we think is right. And through it all, keeping our patients first, right? The reason that so many of us have pushed against this particular suite of regulation is because we think at the end of the day it's going to harm people that we take care of. And so just kind of keeping that in mind through everything. So I started out with my first trip to DC. I'm young, I'm fresh, I got the wired headphones there because that's all we had back then. And you can see the one from my most recent trip, and there's a lot more gray. The headphones are wireless now, so I'm really happy with that change. But it's been a long road, and I anticipate having to keep doing this. So there's lots of people to acknowledge. So obviously, this is just my journey along this route. Lots of people within the department, and I know there's not room enough for the entire faculty here who've been so supportive over the years. Our government affairs folks have been wonderful in really facilitating us as an institution responding to things. Ed Ashwood is my mentor from ARUP. He's now at University of Colorado. Has been really important. Association for Molecular Pathology. There's multiple more people that I need to thank, but also especially Jennifer Lieb and Megan Anderson Brooks, who've been consultants I've worked with for many, many years now as part of my role at AMP, and then College American Pathologist. So with that, if anyone has any questions.
What is your analysis of why, when Trump was elected, the FDA backed off? Were they backing off from everything and just because they weren't sure of what was to come? And then the second question, completely different, is it was only at the very end that you talked about the involvement of the UW governmental affairs people, and I think that's an enormously important component of this, and if you could discuss a bit more about that.
Okay. So the first question was why the FDA changed their stance when President Trump was president-elect. Yeah. And so the FDA is an executive branch administration, and so the president would choose a new head of the FDA and political appointees and things like that. So most likely what they saw was that the leadership was going to change. And so if the current leadership versus potential future leadership had a much wider spread on their views, you might change more people in leadership positions. So I think it was a very tactical.
So there were many issues they backed off on. There's nothing special about this.
Yeah, I think this one was probably just because it was very, very close to being finalized. And so again, it also comes into that whole issue of, if a regulation is passed within a certain period of time, you can just wipe it away. And so, I think it was a strategic retreat more than anything else. So rather than eliminate all that work, it kind of gave them the chance to fight another day. The second question was related to the role of UW government affairs in this whole process. And so, the university, so all universities have some sort of government affairs office. And the reason is that, we have a very important role in our communities, right? We're educating at least local individuals as well as, people nationally, internationally. We bring in lots of money for research. We bring in lots of money for clinical care. We take care of patients. There's all kinds of reasons why universities are important. And so things I've learned, there are people whose jobs are to make sure that the university's interests are represented in Washington and that we convey those to lawmakers and their staffs. And so, in engaging with these folks, we were able to describe, here's a potential issue, here's potential implications, this is why it's important. And luckily we have, individuals who really are willing to have that conversation and understand the issue and be open-minded about it. And they also ask really good questions, and they also come up with really good strategies on how to deal with things. That's not universally true. And so there are other institutions where, for whatever reason, they're saying, this is an important issue, but we have something else that's important. This is what we're going to focus on. And we've seen examples of that. But really what it's allowed us to do is, a letter from Dr. Baird, it has a lot of weight. Letter from other people who are Dr. Baird's bosses, for example, that might have a little bit more weight. And so that's one of the things that we've learned is, to leverage the resources that we have available to us. Dr. Baird.
Thanks. That was absolutely wonderful. And I'd also just like to tell everyone here, we communicate as chairs across the country and very few other departments have someone like Eric who's really as connected and as successful in advocacy. So thank you very much for what you're doing. I don't want to put you on the spot and ask you how this is all going to end up, but how is this all going to end up? and maybe I can specify that or make a more specific question. I just ask you maybe a simpler question, which is, are there things right now, something's going to change. The status quo is not likely to have to continue for 20 years. Are there things that pretty much everyone, including yourself, sort of agree on is going to happen? Are there things that we know are going to change?
So, okay, I'll paraphrase in case people couldn't hear that. So, University of Washington Department of Laboratory Medicine and Pathology is awesome, and we are exceptional in so many ways. The next question is, what's the end game, and what are there things that are absolutely going to change? And I think at this point, the way to look at this is there's been a lot of attention, not just in policy circles, but in the media and public interest groups, et cetera. There's a tension here that isn't going to go away. And I would also throw in that all the things that happened during COVID related to laboratory testing really influenced the public in terms of their perception of what laboratory testing is and how it should work. Okay, so something will change. The first question is, what's going to happen with the guidance or the rulemaking that the FDA is proposing? There are a couple of different alternatives. One is a very light touch, and one is a much more heavy touch. And we just have no idea what's going to happen. If it's a light touch, maybe it'll be something as light as laboratory developed tests can be regulated by the FDA. It could be something that is that simple. But what it does is it establishes a precedent. And so if that sails through, then they could come back later and do things that were a little bit more onerous. If they decide to do a little bit more heavy touch, there's some interesting things that could happen. One is the authority of the FDA to regulate laboratories is a little bit questionable. It really comes down to a couple of words from legislation that was passed in 1976. And there was a Supreme Court decision, I think it was last year or the year before, that basically said that if Congress didn't give you the permission to regulate something, you can't, which was a huge sea change. It was related to the EPA, but it impacts this as well. And so what I anticipate happening is something will come out from FDA. There are going to be lawsuits from organizations. Who knows where it's going to fall out? So that's kind of the most immediate thing. Longer term, I think a lot of groups have recognized that there needs to be some changes. The laws that we're operating under, so the medical device amendments, those were passed in 1976. CLIA amendments that we operate under were passed in the 1980s, right? There are tests that we are written into law that we haven't done for decades. We need to update the regulations to reflect what we're doing. And there are groups, a lot of professional groups are getting together now and saying, what are the things that need to be changed? So I think we'll start to see some alternative proposals come out. They'll be somewhere between what FDA wants and where we are now, somewhere in the middle. But stay tuned, I think is the answer. I think Erica had a question.
Yeah, first I want to thank you for your tour de force. That was wonderful. And I want to mention that AAAS has fellowships in Washington, D.C. for scientists and MDs. At any time in your career, you can apply for a one-year fellowship there. I had the Science and Policy Fellowship after I got my PhD, and I'm happy to talk to anybody about that opportunity. It's just 1 year, you work on Capitol Hill, and you can have a lot of impact working in somebody's office or on a committee. So that's one thing I want to say. The other thing, the question I had was, have there been tallies of adverse events, of these horrible things that are happening as a result of LDTs not being regulated by FDA? I know they had a document, I have this document, of 20 bad ones. 20 bad ones. But we're talking like a bazillion of them. Are there other documents that non-FDAers have written about the alleged harm of these tests?
So the question was, are there any data on the potential harms that have actually occurred from laboratory developed tests that are available? There are individual examples of things that have happened. In general, they affect a small number of patients. Probably the most extensive document we've seen is this 20 test document that the FDA put out in 2015. What's interesting about the 20 test document is that, so this is as part of the push to get regulation, FDA put together what they considered, what most people would say was their 20 best examples of laboratory tests that have gone wrong and how they've harmed patients. The Association for Molecular Pathology very quickly did an analysis of those 20 tests and found that 18 of those examples were things that the FDA would not be able to regulate because they were medical practice. So, provider doing something that they're allowed to do, but the FDA can't regulate the practice of medicine. Several of the tests they gave as examples actually don't exist. So they refer to specific tests by name that have not ever been done and are not offered to patients. There are things like that. And so the harm is really ethereal and hasn't been well demonstrated on a systemic basis at this point. I think, Andy.
Can you talk about VITAL and whether or not there's benefits, and should we try to revise that still?
So Andy is asking about an alternative piece of legislation called the VITAL Act, as opposed to the VALID Act. And this was a piece of legislation. It was actually very straightforward. It was introduced, I think, in 2019, if I remember correctly. And it basically said that laboratory developed tests are the purview of CMS. FDA doesn't have jurisdiction. Really, again, drawing that very clean line of who's responsible for that. The other part of it, because it was, I guess it was 2020, the other part of it was because it was in the middle of the COVID pandemic, was basically related to COVID and doing investigations and things. So unfortunately, that's a piece of legislation that one senator sponsored, a Republican senator, and other people haven't supported it at this point. So again, kind of that strategy thing of like House side, Senate side, et cetera. But it has been reintroduced. So I think that'll be part of the discussion, kind of going back to Jeff's question about where things are going. So if we do have more legislative proposals, that will definitely be part of the discussion going forward. But I think at the time being, it's not going anywhere.
When we're talking to our senators and our representatives, should we use anecdotes or data? Data can be very powerful in terms of saying, like, we presented the paper that, this is how much it will cost every individual. This is the detailed analysis we've done. But anecdotes tell stories. Mm-hmm. And like with Konnick and Rogers, is it anecdotes or data that people listen to and then motivate people to make these decisions?
So Brian's question is, when we're talking to policymakers and people who can influence the process, do we present data or do we present anecdotes? And it depends on your audience. And so one of the things, again, lesson I've learned is that when you're talking to these staffers on Capitol Hill especially, they're young, they're generally in their 20s, super smart, very motivated. They also have meetings like every half an hour for like 10 hours a day. And, they basically, during the course of the day, will have all these meetings, they'll summarize things and tell their boss. And so if you have a story that, they can remember and resonates with them, that actually will probably have more of an impact on what they tell their boss than, sheets and sheets of data. On the flip side, thinking about, so right now, the potential rule that the FDA is coming with is at the OMB, so it's at the White House. And it's being looked at by economists, for example, health policy economists, people who are very data-driven. And so if, for example, within the next couple of weeks, you wanted to get a meeting with OMB and say you wanted to take your half an hour to discuss it with them, they would be very data heavy in terms of they want to know what are the economic impacts. Individual stories are great, but what is this going to cost the healthcare system? What are the things that we're not going to be able to do as a result? So again, it's kind of having that situational awareness of what's going to work. The other thing is that I kind of mentioned the flexibility piece of it. So again, folks on Capitol Hill, super smart, young, educated, huge variety of backgrounds. I mean, I've talked with people who are art history majors, but they're covering healthcare. And I've talked to PhDs who are taking a break from, doing bench work and really understand the minutia of, genetic engineering, for example. And so it's one of those things where you just kind of have to be ready on a moment's notice to say, oh, I'm dealing with this kind of person, and this is the kind of information they want. And, it's, again, it's just it's like a social skill plus, understanding your audience. So again, it depends. So both. Josh.
Eric, thank you for the great talk. I wanted to go back to this issue of documenting harm. And I think one of the objections that I know you and I have both heard, and I suspect others have heard, is citing the sort of pro-valid side has cited or referred to warning letters that laboratories have received or pointing to fraudulent testing for COVID, in Washington State and Utah, where labs were not reporting results or, failing to do quality control and that sort of thing. And I think about labs that we don't let our clinicians send specimens to because we don't trust them, even though those fraudulent labs or the labs we don't trust have CLIA certifications. Where in the discussion is this is any understanding of regulating, you can get through FDA approval, but if the lab is poorly run, that's the safety issue. And so help us understand that sort of rule.
Ooh. Okay. So. Yeah. So again, just rephrasing the question. This is a complicated system. We have this regulatory piece of the test itself that would be FDA approved or cleared, and then there's the issue of the laboratories themselves and that practice aspect of it, and then layer on top of it this whole issue of all the other problems, whether it's fraud or mismanagement or et cetera. So I think you really summed it up well, that it is complicated. And for those of us who've been doing this for years, right, it's like we think about all these different aspects of it, but so many of the people who are making the decisions, they don't really appreciate the complexity. So kind of with that, again, kind of going back to some of the things that are really important that I've learned over the time I've done this, is that you have to, how do you eat an elephant, right? You eat it one bite at a time. And the same thing here. And so, there were folks I met with on Capitol Hill literally for 7 or 8 years, multiple times per year. And what's nice is that, the first time you meet them, you can give them that simplified version of this is important. And then you can expand and build up on it over time. And, I think that would be one of the things I would say is that, this kind of stuff is not something that we deal with, at one point in time. This is not just a crisis management thing. This really is like a long-term investment in trying to help people understand the complexity of the issue. And again, advocating for working with government affairs within the university, because they'll be able to understand it, and then they'll be able to simplify it in a way that they can transmit that to the folks who are policymakers. So I think that's the part of it. And also, like you said, there's this issue of things like fraud. And we've seen some really good examples the last couple of years, and people going to prison for a long time, appropriately so. And, I think they're, just calling it what it is, right? That, yep, that person broke the law, they committed fraud. That has nothing to do with, the regulations wouldn't have touched that, right? If they want to break the law and commit fraud, they're going to do it, whether they have an FDA approved test or they're developing an LDT. And so, and just kind of stopping it there. So again, I think it's a complex story, and kind of going back to Brian's, thought about, do you tell a story? And it's, you tell multiple chapters over time, and it's like a bedtime story with your kids, right? You start with the simple ones, and then you get to the more complex ones until they can read it on their own. Yes, back in the room.
I wondered, I had a couple questions. One is, have you found whether the Supreme Court's Dobbs decision has made abortion interventions for this issue? And the second question is, it sounds like this is a story of two basic opposing positions, which there's no convergence or no possibility of convergence. Do you think, or why do you think that this issue in particular seems to have no room for compromise? And I'm not saying compromise is always good, but that's the way it seems like.
Yeah, and so for the first question was related to the Dobbs decision, and has that influenced? I wasn't quite sure what the question was, but
so the controversy over abortion has any implications for either the opportunity to regulate or this issue that you're describing?
Yeah. So whether the Dobbs decisions influence all this, there are aspects to this that people have brought up related to that, specifically around the non-invasive prenatal testing. And again, you could argue it different ways, and people have. So there is that's controversial, period, and there will be controversy. Your second question was kind of this dichotomy between opposing sides, if you will, where one group thinks that regulation is absolutely necessary, and then another group says that there isn't. And it really is probably more of a continuum. I think I probably exaggerated that dichotomy a little bit. It is a spectrum. I think at the end of the day, thinking about compromise and, going back to Dr. Baird's question, like, what is the end game here? Something's going to change, right? And I would argue that the two extremes are probably not the right answer, but it's somewhere in between. And what are the things we can agree on, right? And so the things we can agree on is that our testing should be appropriate, our testing should be accurate, our testing should be safe. There are things that we can all agree on that we want and we think are important, and that's probably the starting point. Is okay. Here are the things we agree on. What is our current system? Are there things that we can improve about the current system to move it to a more satisfying new state? So part of the problem has been that there have been a lot of things moving the last couple of years, and so we'll see as things go forward. But I'm still hopeful. I'm still optimist. Okay, and I don't have any questions.